Well, welcome to today's special event, Sports to Neuro, a Masterclass. This is the first installment of our new series, Neuro-Optometry Reimagined. We are privileged to have Dr. Charles Shidlofsky, a distinguished expert in neurodevelopmental optometry. With over 30 years of experience, Dr. Shidlofsky has dedicated his career to assisting patients with a wide range of vision and neurological challenges. In addition to his clinical practice, Dr. Shidlofsky works with several professional sports teams in the Dallas area, as well as weekend athletes to enhance their visual performance. He is also the clinical director for the Special Olympics Opening Eyes program and earned his fellowship with the College of Optometrists in Vision Development in 2011. Beyond his clinical work, Dr. Shidlofsky serves as an adjunct professor at several prestigious optometry schools and is the current president of the Neuro-Optometric Rehabilitation Association. Join me in welcoming Dr. Charles Shidlofsky.
First of all, I thank all of us for having me on tonight, and thanks for our crew here today. So today we're going to talk a little bit about, we call it sports to neuro. So we're going to cover sports vision. I'm going to cover a variety of different topics today, and hopefully it'll be interesting for everybody to see. So here's our topics. So what is neurooptometry? A brief neuroanatomy of vision. If you're not understand neurooptometry, you really have to understand the neuroanatomy of what we're talking about. So we get into that. We'll talk a little about autism and sensory processing disorders, acquired brain injury, sports vision, and then kind of a newer subject to a lot of you, visual snow syndrome. But I've seen probably close to 200 visual snow patients now from all over the world. And so visual snow is something I'm going to introduce you to a little bit tonight for many of you. And we're going to talk about some of the neuro-optometric treatments that we do and how we use, and at the end, we're really want to get into how do we utilize tinted contact lenses as part of one of our treatments. So let's just jump right into it and get going. And, you know, when we talk about what is neurooptometry, the roots is behavioral optometry, going back to Skeffington and others of his generation, of that generation of people. That's really where it got its start. And then early on, you know, you had all VT practices back in the 60s and the 70s and the 80s. And then we started to see some organizations come about. In the 70s, we had COVD was formed. OEP has been around for even longer than that, being probably the first organization.
Skeffington.
What? With Skeffington, yeah, absolutely, with Skeffington. So, and then about almost 38 years ago, NEURO came about. And then, so it's really evolved over the last 40 to 50 years quite a bit. And then really, as I said, in the last 30 years, you started seeing this development into neurooptometry, where you're starting to deal with patients with traumatic brain injury, concussion, and stroke, and things like neurological issues like visual snow syndrome and other neurological issues. And now immunological injury. What am I talking about there? What we're talking about there is what we all went through a few years ago, COVID, and vaccine injury also, because I see both. So it's really kind of another element of what we're seeing in dealing with neurooptometry. So that kind of gives you kind of the basics of it. So when I break down vision, I think of it as answering three major questions for us. What is it we're seeing? Where is it in space? And where am I in space? Those are the three questions we have to answer with everybody. And interesting enough, when patients have neurological vision problems, a lot of times the what is it and where is it actually works pretty well. They can read an eye chart. They can usually see, you know, if they're properly corrected, see 20/20. But the where am I is the big bugaboo. That's where people have trouble. They lose concept of space. And we'll talk about a little bit about why that happens. So oftentimes it's in the literature now, it's broken down. The vision is a bimodal process. You have a focal system and an ambient system. And I'm actually kind of changing my terminology a little bit. I'm really using kind of the neural pathways now. I'm calling it the retinal cortical pathway. Okay, that's the retina all the way to the visual cortex. And I'm using the term retinotectal pathway for the other pathway, which is more the ambient pathway, which occurs more in the brainstem and the midbrain. So the focal system is telling us what is it and where is it, right? There's cell types within that system called parvocellular and magnocellular cells, and we're not going to get deep into what those are, but they feed into different parts of the logic nucleus in the brain, and that's how they're differentiated. But they start in the retina, where your magnocells are primarily in the peripheral retina, and the parvocells are primarily in the central retina. And it's really a conscious processing system. So what we mean by conscious processing system is our eyes have to be open. We have to be taking in a conscious sensory experience, right? Whereas the ambient system it is telling us where am I, and it's primarily magnocells that are involved here, and it's subconscious processing, and it gives us what I like to call sensory motor match. The way I like to think of it is I call it the sensory funnel. And you're funneling all the information from our lower bodies, our tactile system, our kinesthetic system, and coming up through our spinal cord, auditory, vestibular, and we're all putting it together, and it's funneling that information up to our brain for processing. So it gives us information about where we are in space, midline, body awareness, posture, and orientation. So that's a good way to think about that ambient system. So about 20% of the fibers from the peripheral retina, both eyes, delivered to that ambient system. Okay. So, but when most people think about vision, they're thinking about the other 80%, which goes to the visual cortex. And that's important. Obviously, that's the seeing part of it, but it's that ambient system once again. That 20% of the fibers, which is responsible for spatial matching, the kinesthetic, proprioceptive, vestibular information, and it feeds back actually into the visual cortex afterward. So that's kind of the complex elements of how we talk about anatomy. So we talk about what is it, where is it, and where am I? And it leads us to something else. What do I do with it? And how do I do it? Okay. So I love to kind of think of it as one thing leads to the next. And this is kind of really tells us how we go about life, in our visual world. So what is it? What do I do with it? Deals with a lot of perceptual and cognitive elements to it as well. How do I do it? Also perceptual and cognitive. So we always have to think about that as part of the process. So here's a nice little map of how our brain's hooked up. So just going back here, you have the retina. You have your peripheral retina over here, comes through here, and it goes to the lateral nucleus where it differentiates. It has different layers. The first two layers are magnocellular, and the next four layers are parvocellular. Comes back here to the visual cortex for processing, and then you have the what processing here, okay, and the how processing that goes up that way. And then you have the other pathway that comes to the superior colliculus and also to the pulvinar, which is part of the thalamus, and then it feeds back up to the web, okay, and ultimately comes back through that what we call the dorsal stream, which is this path, and this is ventral stream down the week. So that's the anatomy of the system. So now I like to put all the pieces together. Okay, so we'll call the central vision as focal. It's primarily parvocellular, and primarily what? So that's taking the anatomy and how that system works and puts all the pieces together. So so it's your detail discrimination, your visual acuity, your attention, your concentration, orientation to your consciousness. It's a slow processing speed. Okay, you always think of a computer chip. It has a lot of RAM. It requires a lot of RAM for that part of the brain to work. So it's much slower in processing. And it's mostly higher level processing. And then we talk about our peripheral system, which is ambient. It's primarily the magnocellular. It's telling us where we are, right? So you have that's for spatial orientation, posture, balance, movement, anticipating change. It's a very rapid speed in processing, and it's a lot of times used in fight or flight or survival. So it's a very important part of the system. But the trick is, as optometrists, we don't know how to measure it, right? It's not something we can't measure acuity, so it's a much more challenging thing to measure. But you have to kind of go outside the box and think about it and measure it kind of like, how would you measure it? Right? Look at balance, right? Balance becomes really important way to measure it. So you can look at things like that instead of just your traditional optometric testing. And this is a really beautiful graphic that Dr. Shidlofsky came up with probably 20 years ago. I've been using it in my lectures forever, but it's a great picture of it. So you have your eyes here with the M's, with the magno cells, and the blue areas are the parvo cells. And once it comes back around, geniculate nucleus, back to the visual cortex, and then you have the one pathway that comes down through the brainstem, which is, notice it's red, so that's magnocellular. And that's your vestibular nuclei right here in your cerebellum. So that's where the balance piece comes in. And then once again, and it shows it feeds back up to all different parts of the brain too. So really an intricate system and a beautiful system if you think about it. It's really a cool thing to see how the brain actually all hooks up together and it gives us our visual world. So what happens when we have a situation where we've had a traumatic brain injury, or we have a child who's struggling in school, or we have the athlete who's struggling on the athletic field? What is really going on with a lot of these people? How do we respond to it? And I always use an example of a tennis player. So if you're playing tennis, what do you see? You see it in the net, you see the lines, you see the player you're playing against, you see the ball, right? What happens when you chase hard after a ball? What do you see? Just the ball. So what happens is your system does what we call overfocalization. It locks down and blocks out that periphery and you lock down there. It was a survival mechanism. Think about it. Tigers chasing you through the woods. What do? You got to look what's right in front of you, right? It was the survival mechanism. But when you have a child with autism, you have a brain injury patient, and their system is compromised. The first thing they do is they lock down and come collapse. What we can do as healthy individuals is we can open that right back up again. Think about the next shot in tennis. You get ready to you chase hard after the ball, you saw just the ball, and you got it back over the net, and you get ready for the next shot, and you open yourself back up again. But on the other hand, child with autism, they can't open themselves back up again. The athlete, if they have a hard time opening themselves back up, they're going to have a hard time passing the ball because they don't know who to pass to. Okay, so that's what overfocalization is. It's causing inability to release detail. The environment around you becomes overstimulated. So what happens when we have a patient who's had a concussion, for example, they can't go into a grocery store. It really stresses them out, right? That's because of that environment just becoming so overwhelming to them. Movement in the environment becomes chaos to the visual system. Okay, print on a page becomes a massive detail. And that's why a lot of kids have reading problems. Reading problems are really, a lot of times they get so collapsed that the periphery runs into the central. And what ends up happening is, it's really interesting. They'll tell you they can read big words, but they don't see the small words. And the reason is the small words run into the big words, so they don't see them. That's the answer. So this becomes a really important organizational component of the whole visual system. And movement of the eyes projected in the field, causing movement of the background. So that's where print moves on the page. We see a lot of that with kids as well. So this is the graphic I've had, gosh, a long time, but I love to show it because this is kind of an illustration of what we're talking about. So if this is your sentence you're looking at, a normal, healthy individual might look at it like this. You're moving your attention across the field. You're seeing the next word in space. You're able to read through this very, very easily. And then you go to the next one, and the person with the collapsed attention, this is kind of what it looks like. So what do you think happens to their reading pattern? Falls apart, right? Because you really can't focus on you're reading parts of words or seeing individual letters at a time. So, and that collapse does that to you. So that's what focalization is, and that's what's important about understanding how this is how the system reacts. Now, obviously, it doesn't look like that, right? It looks normal to them, but I show it to you for illustration to understand kind of what they're really seeing. Many of the people we deal with have difficulty, and it really doesn't make a difference if it's a child having difficulty in school or a person's had a neurologic injury like a brain injury. if they're young enough, they're going to also have some sort of accommodative dysfunction. A lot of them have convergence insufficiency or emergence dysfunction. Really, really common things that we see. They're very common in children. Convergence insufficiency is very common in ADHD, and it's also very common in concussion and brain. So, and the interesting thing about convergence insufficiency, if you think about it, I'll use a brain injury example because or a concussion example because it's really an interesting way to think about it. Because, you know, most people would think, well, it's a problem with the muscles, right? Well, if you think about it, if it was truly a problem about muscles, the person with concussion had normal vision today, and then they get the concussion the next day, and then they can't converge their eyes. Did we move the muscles? No, we didn't move the muscles. What changed is the input from the brain to those muscles. Okay? And that's what convergence insufficiency is. It's a mismatch between where our brain thinks something's in space and where our eyes think something's in space. And that's why so many people have vergence problems. And even kids who are having difficulty in school, but even going to that concussion patient. So the proof that it's not a muscle problem is the fact that it can be easily developed in a very short period of time. Most immediately.
80%.
80%.
80%. ADHD have
Convergence insufficiency. Absolutely. And about 80% of concussion patients have convergence insufficiency. Yeah. So very, very common there. And then we talk about oculomotor difficulties. That's moving our eyes, right? And we talk about pursuit movements, difficulty tracking, like a car going down the street, a teacher walking across the room, things of that nature. That's what a pursuit movement is. And then we have the saccadic eye movements, which are jump movements. So if I'm looking at one person over here and I want to jump over and look at the person here, I make a jump movement. But it's also what we use in reading. Right? When we're reading, we're using a jump movement. And if you think about it, there's really nothing. I like to simplify. I'm always a big believer in simplifying. If you think about it, there's really 4 parts to a saccade. There's a fixation, there's an attention, then there's the saccade and a refixation. And the problem in that group of 4 is the attention. Because if I collapse space, what happens? I have to move my head, move my eyes. Right? So when you get that collapse, and it goes back to that overfocalization, we get that overfocalization, this ties together with the core eye movement. And that's why many of them have second core eye movements. Sometimes we deal with patients that have nystagmus. Sometimes we have cranial nerve pulses. I see those quite frequently in my brain injury and concussion patients. 3rd, 4th, and 6th cranial nerve issues are really, really common. If you're in a concussive injury, 4th is probably the most common that I see because it's a twisting shearing injury. And typically, you know, I'm going to assume that if they have a vertical imbalance, it's going to be a 4th nerve until it's proven otherwise. That's kind of my approach to the problem. So other components of spatial science we already talked about. Where are we in respect to the external world? So you have vision, vestibular, and proprioceptive information that's telling us this, right? And then localization, there's really 2 types of localization. It's egocentric. That's where our position of objects with respect to me. And then there's oculocentric, it's position of space as compared to my eyes. So, and you can have egocentric problems and you can have oculocentric problems. So we have to kind of break that down as well. So who's an oculocentric problem? An amblyopes, right? An amblyopes, that's one good eye, one vision with 4 eyes, and so everything surrounds around that. That's an easy way to think about it. So now let's kind of jump into autism a little bit. I just find it's such an interesting topic, and I've been working with autistic kids for 25 years now, almost 30 years now. I just find it to be such an interesting field of understanding because most of my autistic kids have 20/20 eyesight. So the parents go get their eyes checked at the school, and they see 20/20 here, and they see 20. Nothing wrong with your child's eyes, but they're done. Have a nice day. But there is. Okay, it goes back to that where am I system again. Okay, so these kids have lack of eye contact. They stare at spinning objects or light. They have fleeting peripheral glances. They use side viewing. They'll look at a TV like this, okay, sideways. They have difficulty attending to anything visually. and they have an altered center of balance. Many of them toe walk. I have some that heel walk too. So I've seen it both ways. I have some people that pronate or put their feet the other way, in the opposite direction. So you have to understand that these type of things are indicating to us there's visual problems. The problem is that they get checked 2020. Okay. So you have to kind of be looking for these things and seeing how you can alter their visual world so that they're able to process information better. They also have hypersensitive touch and vision. So they have a tactile effects of this. So sometimes the problem is you put glasses on them and they throw the glasses across the room because they're actually defensive. Or a lot of times the treatments for that is through brushing techniques. You brush their skin, you brush areas around there, get them adapted to that sensation. There's a visual defense of this. You bring something, you get close to their face with your ophthalmoscope, right? And it's like they're running out the back of the room, okay, because they're so visually defensive. And they oftentimes have really hypersensitive visual stimulus to certain visual stimuli. They're very hypersensitive, but yet looking at a ceiling fan, they can do that all day long. Okay, that motion is really helpful for them and calms them. And then what we call difficulty visually holding still. They're constantly scanning information. If you think about it, if the way I like to describe it to patients is, if you have a person's face and a light switch, obviously for most people, a person's face would be much more interesting, but for them, there's no more interest in the light switch than there is in a person's face. So I want to look around at everything. One of the best tricks I have in my toolbox for patients on the autism spectrum is using yoke prisms. And it's amazing. I call it the smile test. So I put the yoke prism on them. If they start looking around the room and they smile, I know I've hit the right lens. Okay. They usually can't verbally tell me, but you just know by watching them and observing them. So it's a really, really cool thing to see when you really hit the right lens. This was a graphic I came up with years and years ago also, but I still use it obviously. Actually a teacher did this for me because I am not an artist, and I drew a little pyramid and I had this out on a pyramid, and she says, I got to fix that up for you. So she drew this for me. And it's really how we learn. And I called it the learning tree. And you have an auditory channel and a visual channel and a sensory motor channel. And in order for our systems to work efficiently, we have to have integration among those three channels. Okay. So once we create integration of these three channels, then we can process words, word decoding, flexibility, shifts between channels, and reading comprehension. So let's talk about this. Is a really interesting topic because then we can talk about things like dyslexia, right? Which is decoding issues. But if they never develop this down here, what's the chance of them developing things like dyslexia, right? So you have to have this integration down here for them to actually develop the language and learning skills that are important. And of course, you can application to academics in life. Obviously, in academics, you have your higher order thinking skills, your fine motor skills, things like that on the left side. That's the bloom, right? That's the blooming of the tree. Okay, those are the leaves. And then you also have your life and your social skills. So it develops kind of like a tree develops, and that's what I want you to understand about the visual system and how we learn. Because everything we do in vision therapy and vision rehabilitation is based on this concept. How do we learn? Okay, so we go back to thinking about. So the way I approach vision therapy is I'm going to do vision therapy like they learn how they learn to learn. Okay, it's kind of an interesting concept, but if I teach them the way the brain's designed to learn, that's what happens. It becomes a permanent change, and it really makes a huge impact on them. If I just work muscles, not going to work. It drives me crazy. I go into, I see people and they go to maybe an occupational therapist or a physical therapist, and they're doing, they just had a stroke and they're doing convergent skills. And I said, why are you doing that? That's way too difficult for them. They haven't even done the foundational stuff. If I redrew this picture right now, I'd add soil to it. You know what the soil would be? The soil would be nutrition. It would be sleep. would be exercise. Okay, that's really the soil that everything is based on. But nonetheless, that's what you have to understand. You have to do vision therapy the way this is designed in order for us to be able to be successful in therapy. And there's really two types of therapy. There's passive therapies and active therapies. Passive therapies, we use therapeutic lenses, yoke prisms, tints. A lot of people are using NEURO lens now. Occlusions. Those are therapeutic lenses. I call them passive only because they're not actually doing any activity. They're just wearing the lenses. Okay. But while they're doing their normal everyday activities, they're doing vision therapy. Okay. And then active therapy is what we call vision rehabilitative procedures, enhancing accommodation and convergence, suppression, smoother and more accurate eye movements, things of that nature. That's what we're trying to accomplish with active therapy. This is another of my colleague Deborah Zielinski's drawings, and I love it because this kind of sums up lenses as themselves. And lenses and prisms and filters. So I'm going to kind of draw this out here. Actually, I can do it this way. This is even more fun to do it this way. So let me do this real quick. If I get it to work. Oh, no, I can't. Never mind. So anyway, you have your lenses. Here, first of all, here's your what is it, right? Then you have lenses. That's your smooth cylinders. That's your central eyesight. That's primarily parvocellular. Okay. And then you have where is it, which are your non-yoke prisms. Okay, and it's telling you size, big or small, and it's magnocellular to some degree. And then you have your yoke prisms, which is where am I? Where's your body? Okay, it has more to do with distance and spacing. Okay, and then you get into your filters. So this is where your syntonics come in. And what else is filters? Your Altius lenses are filters, right? So this is where the Altius lenses get really interesting. So and really any type of tinted lens becomes interesting. So you have occlusion, which we might use by nasal occlusion, or we might use patching, although we don't do that much anymore. But you might use some sort of occlusion and it's going to change the luminance of the system, right? But then you might use tints, and that's what's interesting about that. And you notice I picked up a thing called conio. Conio cells are cells that are between the magno and parvo cells, and up until about 10 years ago, we didn't even know what they did. But now we're starting to understand that they have a lot of really interesting elements to them. They help the communication of the system. They may be involved in suppression of images. But what's interesting about that is you see this IPRGCs right here. And we're going to talk a little bit more about IPRGCs later, because that's kind of the theories behind using tinted lenses and how it affects that IPRGC system. And we'll talk a little bit about that, because that's the newest cell. The corneal cells came around about 10 years ago. IPRGC has been identified since the 1920s, by the way, but it's really just being studied now. So it's kind of the latest and greatest, so to speak. I went to a meeting called Society for Brain Mapping earlier this year, and it's the first time I really heard long discussions on IPRGCs. It's really a hot topic right now. So what are our goals in treating? We want to organize visual space, gain peripheral stability so they can better attend and appreciate sexual vision. In other words, first thing we fix is peripheral. We fix periphery first, and subject starts getting better. Okay. Gain more efficient eye coordination and visual information processing, improve ability to focus, improve eye teaming and eye movement skills. That's our goals. And allow for integration. That's an important part. I can teach the eyes everything they need to do, but if my body doesn't cooperate with it and it doesn't understand what my eyes are doing, we haven't gotten anywhere. Okay? You got to have that, and you have to also finish off with making sure it drives perception and cognition, because that's where it's going to really affect people's lives. So now we'll jump into acquired brain injury a little bit, get a little bit more specific here. So after acquired brain injury, 70% of our brain is dedicated to vision in some fashion. 80% of all sensory goes through the eyes. Okay, 90% of individuals that have concussion will demonstrate one or more ocular difficulties. Think about that. So I was actually talking to an occupational therapist this morning. On my Thursdays, I spend at the Baylor Hospital right up the street here. And I was talking to one of the occupational therapists this morning. We were having this discussion is that, we see so many people who they come into the hospital, they had a car accident and everyone's worried about their arm or their neck or something like that. But so many of the people have these neurologic injuries affect their eyes and they're not looking about it because guess what? They're 20/20. So they stopped looking at it. But the conversation went, because we've had this early impact by treating in the hospital before they're even released out, we're making a huge impact in their recovery process. And they're actually getting better faster than they do when I see them at the office. They're 6 to 8 months out and they've already developed maladaptations. And we have to break those maladaptations to get them back to the beginning to restart them. So getting them early is always the best thing we can do. The statistic at the bottom came from a study in 2019 on Journal of American Medical Association. 53% of individuals will have ocular difficulties over 1 year. Okay, so it used to be you had a concussion, right? Sat in a dark room for 2 weeks, and okay, it's over. We're done. And guess what? 53% of them had issues a year later. Okay, because they didn't solve all the problems. They just have their new normal. That's what they're living with. And obviously, there's so much we can do now to really bring them through this process and get them in a better place. So studies are showing 50 to 90% of individuals have demonstrated visual dysfunction. I would say it's much higher, 80 to 90%. That's been my experience with it. That's what we've learned in hospital-based care. Common symptoms, headaches, really big issue. Almost, or I'd say a large percentage of my patients are dealing with headaches. The double vision or diplopia, oculomotor difficulties, particularly saccadic eye movements because of the attention component I showed you before. Inability to maintain visual contact. Binocular vision stability and stamina, that convergence problem, convergence insufficiency concepts here, poor depth judgments. A lot of times, when we do depth perception, most people who are healthy can use 20 to 30 seconds of arc. And a lot of our patients who have these binocular vision problems, they don't necessarily lose depth perception, but they may be at 80 to 100 seconds of arc. Okay, and that little subtle difference is actually telling us something. So we need to look at that stereo test to see if we have a subtle drop. It's telling me, hey, they got a binocular vision problem. Okay. The other big one is photosensitivity and glare. I would say a large percentage of them deal with that at some point in time during their injury. It may go away on its own, but it may retain over time. And we have to deal with that photosensitivity issue as well. And once again, this is where tinted lenses have been a huge improvement and a huge help for us to these patients. Here's some basic studies. Common complaints: blurred vision, 46%, diplopia, 30%, headaches, 13%. I think that's way low. This particular study had it that way. Visual field defects, 35%. Cranial nerve palsies, 33%. So a lot of different types of problems that we see. Once again, a lot of times the reason headaches can be low here is because a lot of people don't attribute their headache to their injury. They attribute it to, oh, it's not a headache, because it's common enough without having the headache. Balance difficulties, dizziness, and vertigo are really common with neurological injuries. Decreased attention and mental focus. That loss of cognitive skill become really, really common. Slow visual motor performances, memory problems, sleep disturbances. That's a huge one. Sleep is one of the most important things you can get after a brain injury. But guess what? They have trouble sleeping. So we have to talk about what can we do to get them back to sleeping again. What do we do to get them back to exercise because they have mental and physical fatigue too. So how do we integrate and reintroduce exercise to them? Become very important. How do we test? Well, we got to look at the important skills. We got to look at eye movements. We got to look at eye teaming. We got to look at accommodation skills. Those are all really important elements. Eye-hand coordination. And then really that once again goes back to the integration with the rest of the body, your motor and your auditory systems, visual perception skills, cognitive skills, refractive state. But look at their nearsight, we got to correct their nearsightedness too. If they have astigmatism, we have to correct their astigmatism. Well, can't forget what brought us here. We're optometrists, right? So we got to make sure we do that part of the exam as well. We got to do a good internal and external eye health exam. Particularly my radiation patients, a large percentage of them are diabetic, hypertensive, and then they had a stroke. Okay, so obviously we have to really understand how all those things integrate. So we got to do a good retinal evaluation and things of that nature. And then nutrition becomes an important key because a lot of times we can treat a lot of things like neuroinflammation. We can treat, certain elements with nutritional health. Sleep can be helped a lot with nutrition as well. So nutrition becomes an important aspect of it. If people have allergies, we got to think about how is that allergy affecting them as well, because that will create a hyper state for them that we have to deal with. So important to ask these questions on all my exams. We ask about all these things. We ask about sleep. We ask about exercise. We ask about what nutritional supplements they're taking. And then, of course, we ask them about their symptoms as well. So, in my experience, we see lots of different types of patients when we're dealing with neurological injury. Motor vehicle accidents is probably the number one that we see. Work and home related accidents. Of course, cerebral vascular accidents are really, really probably, I'd say a good percentage of the patients that I end up seeing are cerebral vascular accidents, and they're broken down into ischemic and hemorrhagic. Some of the hemorrhagic ones I have, one of the hemorrhagic ones that are really common that nobody knows about is AV malformations. But yet, those are what I call the surprises, because those are the people who are relatively young, and then all of a sudden they've had a stroke at 21. I had one today in the hospital. Had a stroke at 21 years old. And the reason they had a stroke is that AVM bled. They had a specific type of AVM that actually bled and created a stroke situation for a young patient. So we have to be aware that stroke doesn't only happen in older patients. In fact, it's happening in younger and younger patients. Every year it seems to be younger and younger patients. I can't tell you how many stroke patients I've seen in the 30s and 40s in this past year. Okay, lots and lots. And then what can it be attributed to? I was having a discussion with the nurse recently, and she believes that the COVID and vaccine injury are really contributing, that they're noticing it more and more and more. So it's being discussed in the hospitals very quietly, okay, mind you, but it's being discussed. People are noticing these things. They're noticing these trends. So it's important to keep that in the back of your mind that this may be happening. Just some different things to think about. Like Curran malformation is another interesting one. That's where your part of your cerebellum goes into that ventricle at the back, and they get a lot of neck pain and headaches and neurological issues. So those are just two good ones I threw up there that are one of the, I call them the surprises. Those are the ones that young people get that nobody knows they have until they have a problem. Crime victims, gunshot wounds, physical assaults. Had a nice gunshot wound patient this morning at the hospital. I usually see about, I say at least 2 or 3 of them a month with gunshot wounds. Brain and brainstem tumors, sports injuries, whiplash injuries, concussion. And then you have all the other neurological stuff too. Don't forget those: autism spectrum, multiple sclerosis, cerebral palsy, developmental delays, Parkinson's, dementia and Alzheimer's, Lyme disease. Up in the Northeast, those who know Bill Padula, he's done a ton of work in Lyme disease and how it affects the visual system. But there's so much, and of course here in Texas we still have Lyme disease. Believe it or not, I still see a lot of cases of it. But in the Northeast, it's really rampant, and it's affected a lot of people that way. Headaches. I get about, on average, 15 to 20 referrals from neurology a month just because of headaches. Okay, so headaches are a big area. And of course, you have your genetic disorders, your neurological disorders, you have your genetic disorders. So those are some of the other things that you might see. So when I talk to anybody, and when I talk to optometry groups, but even anyone in any field that is rehabilitation based, I always talk about what I call the 3 R's of therapy. What do we have to accomplish with therapy? So the 3 R's are, first thing we have to do is we have to create rewiring. Okay, we got to got to build them a new road, if you will, and that's what we do with rewiring. We have to do re-education. We have to break the old bad habits, develop new good habits. And then these have to be retainable at the end. We want this to be permanent. So what makes it permanent? We don't train the eyes, we train the brain. Okay? We train the brain, it becomes permanent. We train the eyes, we just work in muscles. Does that make sense? So who do we work with? We work with OTs, PTs, speech pathologists, physiatry, which is physical medicine doctors, neurologists, neuropsychologists, chiropractors, and functional neurologists, ENTs and neuroecology, neuro-ophthalmology, and even general ophthalmology. That's I probably get 5 or 6 ophthalmology referrals. Cognitive rehab specialists, educators, ABA specialists, other optometrists. One of the people at therapists I was talking to this morning was a recreational therapist. I didn't have that on my list, but because I saw her this morning, I thought of it. But a recreational therapist, she's the one who was walking me in the elevator this morning, thanking me for all we do in the hospital. So I really, there's many different types of therapists that we can work with. All right, so we're going to jump out of the brain injury piece and we'll talk a little bit about sports vision. And when I got out of optometry school, this is really what I wanted to do. My 4th year project in optometry school was to work with a college baseball team. And I'm a sports nerd anyway, so I love sports. And so I got really involved in sports vision from very early in my career. And it actually was what led me into doing the other stuff that I'm doing now. But I started with it and then I left it off for a long time. And then I got back into it only because concussions became such a big issue with sports. And it was in the news all over the place that all the teams started seeking me out because I deal with concussions. And I said, guess what? We can do other things for your athletes too. So what is involved? Prevention of sports injuries. That's a big one. There was actually a study that came out of the University of Cincinnati about 10 years ago that showed that if you did vision therapy prior to your sport, the rate of concussion went way, way down. Okay. So if they could see something coming quicker and react to it quicker, guess what happens? They don't get the concussion as well. Okay. Visual skill performance, refractive status. I actually saw a world champion cricket player, world famous cricket player last month. And he came in because he's getting elderly for a cricket player. He's 37. But when I was seeing him, we determined, guess what? He's got a little farsightedness with stigmatism, and he's 37 years old in one eye. And he kept saying, I'm turning away from the ball now when I'm trying to hit. And so I said, I fit him in one contact lens in one eye. Okay, a low power toric lens, just to kind of even him out. So, refractive status becomes an important thing you can do for some of these patients. Visual skills task analysis. I have to understand the sport you're working with. Because sports have different skills. So you're working with it, and even at different positions. You work with a goalie and hockey, it's going to be different than working with a forward in hockey. Same thing with soccer. Okay, so you have to understand what their each position requires. You work with an archer. I was watching the Olympic archery the other day. You work with an archer. It's a totally different vision skill than say basketball, right? So you have to understand what their task analysis is. That way, it leads us to visual skill enhancement. And then we also have concussion management, sports vision. As I said, it's the hottest subject in sports. The professional teams are petrified of concussion. They are petrified. They're almost a little psycho about it. Okay, they're so concerned with it, and they're so concerned with potential lawsuits and things like that. So that's why they're really doing everything they can. They're actually taking a dual approach. They're hiding it the best they can from it, and they're trying to expose themselves the best they can to the experts, so they don't get exposed. But that's what we're seeing in it. And then obviously eye protection and lenses. How do we, pickleball's gotten really big, but the ball's coming flying at your eye. You gotta have some eye protection. Racquetball, squash. I have, younger baseball players who wear eyeglasses. And how do you find the right eye protection for them? Fitting the right contact lens for them also makes a big difference. Just like the example I gave. For eyewear, regular eyeglasses don't cut it. Okay, they're not designed for this, and sometimes contact lenses don't even give us the right protection. So you have to be aware of that. More than 90% of sports and recreation-related eye injuries can be prevented by using appropriate eye and facial protections. This is an old study. It was done in Canada. This is when with the youth hockey players, and it used to be years and years ago. They didn't wear they wore a helmet, but didn't wear anything over their face. And they made it required for the youth players to wear a shield over their face. And guess what happened to the amount of eye injuries? Went to nothing. Okay. But before it was pretty common. So obviously that eye protection piece becomes really, really important. And what can you wear? Well, wearing the proper specs is really important. There's something called ASTM standards that are tell you what you have to wear. And there's even some specific standards for like racket sports and things like that you have to know about. The ASTM F803-19 is the current standard, relates to eye protection for most sports. And then you have the ASTM F3164-19 is standard for the racket sports. But if you put in sports eyewear in your office, you need to look at those standards and make sure that the eyewear is matching those standards. A lot of them don't believe in that, so they won't stand up to them. Contact lenses. Obviously, one-day disposables is probably our number one lens that we're using right now with our athletes, because they, if they're on an athletic field, they get stuff blown in their eyes all the time, things of that nature. One-day contact lenses are a great choice. I like to get the tightest fitting contact I can, so they don't get a lot of movement, number one, and especially with toric lenses. And number two, if sand and dust comes from the side, it doesn't get up under the lens. So a tighter fitting contact is usually a better contact for sports. Now I tell my athletes, I say, think of this contact lens as a piece of sports equipment. That doesn't mean you're going to wear that contact. If you go to wear contacts in your regular life, that we're going to wear the same contact. And that's where sports tinted contact lenses can be really, really helpful for us. Because if we fit them in a sports tinted contacts, they're going to wear that just for their sport. And they may wear their regular contacts for their everyday wear. Okay. So sports tinted contact lenses really can be helpful for us. And then you have your specialty lenses, because you're going to have that patient who has high astigmatism that needs a toric lens. Or you can use a synergized lens, which is going to be a rigid center, soft edge hybrid lens, and that can be really good. Scleral lenses can be helpful for a lot of patients, especially if they have dry eyes. So scleral lenses can be great. The other big thing, ortho-K, not wearing a lens at all during the day, but giving them that good visual correction so that they can see for their sports. And then for guys like me, I still play ice hockey. And I wear my multiple contact lenses when I play ice hockey. Because I want to see what time the game is. But no, but wearing the multiple contact lens can be helpful for golfers, particularly for playing hockey for different sports. So once again, coming down and picking the right lens becomes very, very helpful. And like I said, tinted lenses can be particularly helpful. Not only because of the lack of glare, but also how it highlights the ball, how it highlights everything you're looking at, how it highlights the greens on the golf greens. That's what you have to think about. How is it changing the background? When you put a tint on, what are you changing? Are you changing the detail of the background? You're changing the background, okay? And you're changing that contrast luminance between the two. So by doing that, you're hopefully going to enhance what you really need to look at, and by creating that contrast difference. Obviously, there's a lot of vision skills that we need for sports. Here's just a list of some of them: eye tracking, eye coordination and distance and near, depth perception, peripheral awareness, fixation accuracy,
localization, color perception, gross visual motor control, fine visual motor control, staying focused at distance and near, visual recognition, and visual perception. These are all important skills that we need for sports. Dan Labia at SUNY came up with this really cool little sports vision pyramid. I love to show it. Basically, you always think of where do you start? You start at the foundation of the pyramid. So the first level of the sports pyramid is visual acuity, contrast sensitivity. It's your monocular sensory processing. Okay. Then you have the second level, which is stereo vision and depth perception, which is more your binocular skills, right? So that's your second level. But then you have to take it up to that brain level, right? So your visual decision making becomes that next level. You have to decide, am I going to swing at that ball or am I not going to swing at that ball? Okay. And that's your neural processing. Your next level up is your visual mechanics. How do you integrate your vision with your balance and your other sensory skills? And then can we transfer it onto the field? That's the top of the pyramid. Make it all work together. And so, because if you do fixed visual acuity and fixed depth perception, and your decision making might be a little bit better, but you can't translate it on the field. What have you done? Not a whole lot. Okay, so you have to be able to take it all the way up to the top of the pyramid to be able to help that activity. So for vision testing, not only good enough to do the test and get the results, but you have to look at quality also. Quantity is not the only important factor here. You have to see quality. I'll give you an example just with acuity. They by cover 9, they read the line T, Z, B. Okay, and the next person comes in and PZBCL. They both read 20/20, right? But there's a difference, isn't there? So you have to look at quality and mark out quality as far as it goes. So does it take significant effort or does it happen easy? What's their posture like when they're doing it? If they're going like this. You can't have that going on in the athletic field. They have to be able to be cut still body or still eyes. And if you can't do that, it's going to affect you in a big way. Average visual measurements are not sufficient. Most of the baseball players that I've seen have 20/12 vision or better. Okay. And the reason is they have to have it. So they're dealing with having to process things so quickly. And just a slight decrease in visual acuity can really affect their game. I had one of the Texas Rangers sent me a player, I think it was about 2 seasons ago. He was a 17-year-old out of Venezuela. Okay. And he had very, very subclinical keratoconus, but he was 20/25 And so basically, he was having some struggles with hitting as he was kind of coming into this baseball, into the baseball world at a young age like this. And I ended up fitting him in a hybrid lens to kind of equalize his vision. He was 2015, 2012, something along that with the hybrid lens on. And it just made all the difference in the world. He really started hitting the ball better and really, keeping up with things better. So acuity becomes an important factor for it. And I always tell people when you train for things, when you train a child who's having difficulty in school, you're training a brain injury patient, you take someone with subnormal vision and making it hopefully as close to normal as you can. When you train an athlete, you're probably taking someone with pretty normal vision, you got to make it elite level. Okay. So that's a different thought process. It's actually the same skill. We're actually doing the same exact vision therapy skill, but we're going to load that skill up to a level that it's going to really challenge them. And that's what the cool thing about this is. It's just applied vision therapy in a different way. The most important test we do, and this goes for anything, the number one most important test optometrists do is case history. So with the athlete, we have to kind of go into the case history a little bit deeper. We have to ask them about what sport they play, what position they play. Do they play multiple positions? What's giving them the most difficulty? So you just have to ask the right questions. So that's kind of what we do with a history form. And this is a form that the International Sports Vision Association came up with a couple of years ago. It's on their website. If you remember, you can download this form, customize it for your office. And it's a great little form. And it's 2 pages, front and back, and they fill it out. And that's how we gather the information. Obviously, we talked about pursuits and saccades before. And the way to think of saccades for sports, though, is ballistic eye movements. Okay, quick eye movements, rapid eye movements. Okay, So, obviously important thing to work on with that. There's all sorts of devices out there. This is called the Synaptic Sensory Station, or it does 10 tests for sports. What's cool about this particular device is that it has a huge database. So I took that cricket player. I'll give you the example of the cricket player that I saw. I can actually put in cricket player, professional, and I could put in that he would play. He was a bowler. I actually had two positions. He was a bowler, and I forgot what the other position he was. And I put all that information in there, and it compared him to cricket players that are of similar ability. Okay, to show us where his visual skills were relative to other players. I can do the same for basketball. There's like 100, like 30 different sports. Even referees are in. That we all know that referees need the most. So anyway, and so it's going to do vision clarity, contrast sensitivity. Believe me, I've been playing hockey long enough. I can yell enough to grab somebody. Depth perception, near far quickness, perception span, multiple object tracking, reaction time, target capture, eye-hand coordination, go no go. That's what is included inclusive in this, and that's what's compared in the database. So it's a great little test. This was actually one of the Mavericks draft choices. He was the first Indian player ever drafted by in the NBA. He didn't make it. He had some of the worst vision skills I've ever seen. He was 7'4".
Wait, that's Satnam Singh.
What?
Satnam Singh.
Yeah.
Yeah.
7'4".
Yeah.
Big dude. Okie dude. This is actually a PGA golfer that I went and did a vision screen with PGA, LPGA. Probably 4 or 5 years before COVID. But in that case, we just took the little tablet and just did the tablet. It was really effective. The tablet, you have 7 of the tests on the tablet and 3 on the bigger sensory. So tablet will still give you a lot of information when you just use that. That's what we typically use for screenings. This was actually at the Cleveland Indians training camp. And I went there with Alex Andrews and a few others. We went out and worked with them. You see, we were doing synaptic, we were doing all sorts of different tests in there. We actually had a refracting lane in there too. It was great. It was refracting. We did have a right eye. We did a right eye with them. So it was really a comprehensive thing. And I'll go back and do that again. It was a lot of fun. This is just one of my patients who was a hockey player. He was a junior high hockey player at the time, or a middle school hockey player at the time. And the first area here is his initial test. And then after we trained him, that blue area was just showing his improvement. So we can actually show the before and after with it. So it's really kind of nice that way. Balance testing. With all my brain injury patients, really virtually all my patients that I see that are that we balance test everybody. We can use a variety of different things to do it. We use an electronic system. So, but we're gonna measure their center balance first with their eyes open and then with their eyes closed. Then we'll put them on a foam mat, eyes open and eyes closed. And what that does, it breaks down the visual system. Actually, it breaks down the balance system into its components, which are vision, vestibular, and touch, right? Tackling. So by doing that, we can actually test those different areas. So when they're on the firm board with their eyes open, that's tested. That's really this integration between those senses. When they're on the firm board with their eyes closed, it's primarily touch. When on the foam mat with their eyes open, they're primarily visual. And foam mat with their eyes closed, they're primarily vestibular. So we can kind of break down those different areas. And I even do this a lot with yoke prisms. I'll put them yoke prisms on after I've tested it, after I get my baseline, see the effect of yoke prisms on balance. So that's a really great tool that we can use. But very important post concussion. Now, sometimes I'll say just put them on the mat and watch them. If like I have an autistic child, they won't stand there for a test. We can actually just do it just on the floor, just with the mat, and just observe them. It's not as accurate, but certainly you can do it. All right, next subject, visual snow syndrome. And this is kind of a new area for a lot of people because visual snow was just really identified maybe about 8 years ago. Okay, as a disorder. It will be an ICD-11, by the way. When ICD-11 comes out, they are going to have a diagnosis for it. So what is it? What can we do about it? Quite a bit, actually. So we'll talk about that. It's a new neurologic disorder formerly defined I said less than 6 years ago, but now 8 years ago when I did the slide. It's thought to be rare, but it's not that rare. In fact, now the newest studies are showing that up to 2% of the population may have some form of visual snow. How many people is 2% of the population? About low. A whole lot of people. So my joke is that even if it's 1/2 of 1% of the population, that's a lot of people still. Okay. So a lot of people are struggling and suffering with this in one way, shape, or form. But usually they don't say anything about it. Okay, because they just think it's normal or it's just them. Okay. But now that we've kind of brought it out in the forefront and people are talking about it, now people are starting to identify themselves with it. And I've seen people virtually all over the world with this disorder. And we've been able to help a large percentage of it. It is a diagnosis of exclusion. You have to kind of question them, ask them questions. We'll talk about symptoms in a second. There've been a bunch of off-label drug trials, epilepsy medication, anticonvulsants, altitude sickness medications, migraine medications, epilepsy medications, and guess what? Didn't work. Largely was ineffective. Any medication. So they were kind of stuck about 4 or 5 years ago. Well, we tried all these medications and nothing really seemed to make them significantly better until I had some success with a patient who was actually a baseball player from here in the Dallas area. And another doc in California was having success with some people with visual snow doing vision rehabilitation. And they connected us and we sat down together and said, what are we going to do about this? How we caught lightning in a bottle or do we have something? And we said, let's do a study. So we ended up doing a study. Right during COVID, by the way, we did the study. So here are our main symptoms. Static for longer than 3 months. Constant dots across the entire visual field between the patient and the outside world. Think about an analog TV. Okay. Black and white or color. 24/7. Okay. Eyes closed, eyes open, doesn't make a difference. They still see static. Okay. Think about how debilitating that can be. It's got, I mean, I can't even imagine. And I hear the stories all the time. I still can't even imagine what it's like to see this staticky pattern in my vision all the time. 75% of patients also report at least 3 of the following 4 symptoms. Palinopsia. That's like light trailers, if you want to think about it. Photophobia, nyctalopia, which is difficulty with night vision. Entopic phenomena, which are like floaters. Blue field entopic phenomena, everything seems blue. The background, the surroundings seem blue. Seeing the inside of their own eye, I've heard that description a bunch of times. Spontaneous photopsias, where they just see flashes of light. So those are some of the things that we can see with this. And then you have your non-visuals. Tinnitus, biggest one by far. And I started thinking about this, and I started thinking about, well, isn't visual snow kind of tinnitus of the visual system? All right. Instead of ringing, you just have snow. Okay. So it kind of makes sense. And you start thinking about the anatomy. I'm not going to go back into the anatomy again, but I think there's some anatomical elements to this that make it really, really, really interesting how they tie the visual and the auditory together with this. So the other big one we've heard a lot about is what they call depersonalization. Depersonalization is almost like you're seeing yourself from away from your body, and you're looking at yourself from afar. That's what depersonalization is. It's a really bizarre thing. I've seen it in my brain injury patients too sometimes, but it's a really bizarre attached feeling. Anxiety and depression is probably the most common thing we've seen with it. In fact, I would say it's a precursor for many people. Many of these patients have high anxiety. I will tell you, and you can ask anyone in my office that these patients are desperate in the worst possible way. And that's why I've seen people from all over the world. They are desperate for help. Frequent migraines. Brain fog is another big one that we see a lot of. And brain fog in and of itself is really interesting because when your person has brain fog, what is it telling you? Neural inflammation. Neural inflammation. That's what we're dealing with. Number one symptom of neural inflammation is brain fog. Insomnia and other sleep issues. They're our friend in sleep again. tingling in arms and legs, and sometimes coming by general pain throughout the body. So these are really some of the interesting things that are side symptoms, but they happen. As tinnitus is, I would say, 60–70% of the TB. So we actually wrote a study, and the study was published in Frontiers of Neurology in December of 2022. Efficacy of neurooptometric vision rehabilitation therapy in patients with visual snow syndrome. And the outcome of the study was that vision rehabilitation ultimately helps patients with visual snow. To the point where the Visual Snow Initiative, which is the organization that contacted both of us to get this thing going, they now recognize it as probably the treatment that has been the most effective of any treatment that has been tried to date. So where are we going from here? What type of experiences? And I'm afraid you're getting a precursor for what I'm going to talk about next week. I think because that would be 1 hour just on visual snow. But what are some of the therapies that can be integrated? We have nutrition. Well, once again, we talked about neuroinflammation, but there's many nutritional things we can do to help stem the tide of neuroinflammation. We could talk about sleep also, things of that nature. Guided imagery, help relaxation techniques. We got to help them decrease their anxiety. So it's a driver for this. Low-level laser, sound modulation therapies. And here's our friend tinted contact lenses again. Okay. So tinted contact lenses we started using recently in the last 6 months, and we've now studied quite a few people with visual snow with these tinted contact lenses and had some really good success with at least modulating their symptoms and turning down their symptoms. And specific to the Altis lens with the 2 different colors, we typically use the amber tints for, I would say, a good percentage of our visual snow patients if there's not migraines involved. Okay. If there is migraines involved, then on the green gray, it seems to be a better tint. So that's kind of how we break it down. But a lot of times we give them a pack of each and let them try one of each. See where they like that. We can also use things like some tonics for some of these patients to help them out as well. I like the large majority of patients with some tonics as well. And then I think we're learning some new things by doing some testing. We're looking at ERG and VEP, event-related potentials for using quantitative EEG. In fact, there's one particular finding we're finding very interesting with EEGs right now, using a visual, or we're using visual stimulation, seeing how it affects the EEG. And then nutrigenomic testing. I think there are some people probably predisposed to this who maybe have high inflammatory factors related to their genetics. So these are things we're looking at, and we keep adding to the protocols. I think, mad scientists, and we keep saying, what else can we do to help? We're always looking to figure out new and interesting ways to do it. Which kind of brings us to we'll go back to the tints. We have a peak sensitivity to green. And it gives the sharpest and most other in focus. And then those colors like red and violet seem to be blurred. Okay, and that's just the way the spectrum is set up. Okay, so it's important to understand how the visible spectrum is affected. And this is kind of why we can make changes with it. The patients, the concussion patients that have photophobia, the amber lenses have been like a lifesaver. A lot of times we can do it in FL41 with their glasses, but we can do it amber tints with their contacts too. And then also minimizing aberration. So the big one for us is chromatic aberration. Tinted lenses can really do a good job by limiting chromatic aberration. And because it affects, I've got a lot of different elements. In fact, a lot of people say just the glare and the purple distortion seems to decrease with lenses. So this is kind of just showing a nice little graphic that Altis shared with me. With all this amber, you see that it changes that dioptric amount of aberration you get just by putting that lens on, like 2.2 to 1.1. So it definitely shrinks that zone down, so you get a much sharper focus, and you get a 53% reduction in chromatic aberration to improve visual clarity as well. So that's a nice element of the lens as well. And then obviously reducing that visual noise. It hinders our ability to concentrate, slows our ability to learn, makes it harder to communicate, contributes to fatigue, okay, and worsens migraines. So the interesting area of this has been in the migraines. So let's talk a little bit about that. And just a light transmittance with the different tints here. You can see a little bit difference between the gray, green, and the amber. But I'm going to kind of jump into this. Going back about a year ago, I read this interesting article that had come out about green light, about 2 years ago now, about green light and migraine headaches. And I was really intrigued by it. But they said if you can limit red and you can limit blue light and then promote green, it will slow the progression of a migraine or even reverse the progression of a migraine. I found that to be really, really interesting. I was working with some green glasses at first with some patients, and one of the first, when I first got them in, my associate doctor came in like 2 days later, and she had a really bad migraine headache. I don't know if I could spend my day here. I said, "Oh, you're leaving." So I put the green lenses on her, and about 30, 40 minutes later, she went back to work. But essentially, it really slows it down. And I think you, Janice, used that with the green lenses also with migraine headaches before. So it does definitely slow things down. But this was the study, one of the studies, this is the most one of the more recent ones. Narrowband green light effects on headache, photophobia, sleep, and anxiety in migraine patients. Open label study online using daily headache data. So that was a study that was out in Frontiers of Neurology also. But there was the original study that I read was from, and I didn't put it in here, but it was from 2015. So this is something that came out of Harvard, and it was really, really interesting. Rami Bernstein is in this article, but she was also in that original article out of Harvard, talking about green light. So green is a new thing, and you know, I remember having a discussion with someone and saying, you know, so we originally had the eyeglass lenses. And there's a new eyeglass lens out now called Avalux. I don't know if anyone's heard of Avalux, but Avalux is basically a green lens also. Because I had one of my patients that we recently saw. So I had a visual snow patient come drive all the way from Maine to see us. He got his, it was a really interesting story. He got his visual snow. He was in Afghanistan back 20 years ago, got hit by an IED and developed visual snow almost immediately after. Okay, this is a concussion-based visual snow case. And so we started, he came down and we did his workup, went through and did his evaluation. And shortly thereafter, we let him try the different Altius lenses on. And he's been wearing, going back and forth. I think he's probably been in the gray green one. You like that one the best. Decrease the symptoms. So we put him in that. And now he wants to order a pair of the Avalux glasses for when he's not wearing his contacts. And so that way he'll have something all the time. So Avalux is just a glasses version of what we're doing. Now, the advantage of the contacts is you get full coverage. It's really going to cover more. It's going to block out more of the peripheral light. But obviously, even using an eyeglass, especially the eyeglass lens, very, very helpful for us as well. So it's really good and new information for us to understand the effect of this particular tint on patients with migraines. Because how many people, doctors in here, have patients with migraines? Every one of us, right? We all have patients with migraines. How many of you have family members with migraines? Probably all of us have family members with migraines. So that brings me to this slide. What are IPRGCs? We talked about IPRGCs before. Relatively new thing. Intrinsically photosensitive retinal ganglion cells. That's actually one of them right there. And they're kind of compared to the Rossi cones. They respond more sluggishly and signal the presence of light over long term. Okay, that's their job. They play a major role in maintaining circadian rhythms. There's your sleep piece of it, right? They innervate other brain targets such as pupillary control, olivary pretectal nucleus of midbrain, and help contribute to pupil size. And they contribute to the secretion of melatonin. So there's your blue light. aspect of it as well. Okay, so they're playing a role in conscious visual perception. So these are important type of ganglion cells, and becoming more important. We're just starting to understand them more and more what they do. But I think they're really impacted significantly by using tinted lenses. As we showed in Dr. Zielinski's graphic earlier, obviously part of that pathway that was with tints was the IPRDC. So we're just starting to get, and she's probably the leading scientist in IPRDCs for optometry right now. And she was president of the International Society of Brain Mapping as an optometrist. That was a pretty impressive thing. But and she's done a lot of support for this cell type. So you're going to hear more and more about this because this is something we can certainly impact, and it's definitely playing a role in our understanding of how tints help us. So, and this is another slide. I'll just came out with a wavelength that IPRDC has. And you can see how the lenses, the green and the gray lenses, then impacts the wavelength of the IPRDCs. So you can see it on the top one here, and on the bottom right here with the alphas amber. Versus an FL41 spectacle versus gray green. You can see it much better effect with that green lens coming way up over here. So it definitely makes definitely impacts. All right, we're getting to the bottom there. All right, how can you learn more? There's always good ways to learn more. As I said, I'm president of the Neuro Rehabilitation Association. It's NEURO. The website is neurovisionrehab.org. We're actually doing our annual meeting next month in Orlando. I'm going to show you a slide next about that information about that. So if you're interested in sports vision, the International Sports Vision Association, sportsvision.pro is the website. A lot of great information on that website in regards to sports vision. Optometric Vision Development and Rehabilitation Association. You may not have recognized it, but that was COVD, and they just renamed January 1st this year the OVDR. Optometric Ascension Program, and we have a guest here who's very active in it, Fred. Is very active OEP guy. And they're also putting on ICPO next week in Canada. I'll be doing a lecture on visual snow and hospital-based care. And then Visual Snow Initiative is another program. If you want to learn more about visual snow, I've done about 8 or 10 videos for them that's on their website. It's accessible on their website. I'm talking about how we can affect visual snow with vision rehabilitation. And I just actually with that guy from Maine, the veteran from Maine that we just finished working with, he and I just recorded a video last week, 2 weeks ago, about his whole process of going through therapy and how it helped him. So that'll come out soon, but the whole video there. So visualsnowinitiative.org is the website there. This is the NEURO meeting. If you're interested in coming, 18 hours of continuing education, hands-on lectures and topics, and full-day clinical skills workshops. And you know, it's a great program. It's one of my favorite meetings of the year. We call ourselves the Neuro Nerds. But great meeting. It's at Embassy Suites in Kissimmee, Florida, which is right near Disney World and Universal Studios. And it's all, we have co-credits all pending right now. Actually, some of them's all, since I made the slide, has already been approved. So most lectures will have approval on it. If you want to really learn more, you really want to go to an interesting meeting where everyone goes to the CE, and we have 35 vendors this year, all the companies, including all of us. It'd be great meeting. So I want to thank everyone. My contact information is on here. By the way, since we're in Dallas, and I know this is going all over the country, maybe all over the world, this recording. This is actually sculpture in downtown Dallas. Big eye sculpture. It's about 5 or 6 stories tall. It's right across from the Jewel Hotel. So you ever come to Dallas, you have to take your picture with the eyeball. And thank you very much.
So we're going to open up the floor for questions. So anybody who is online, you're welcome to submit your Q&A through Zoom. read out the questions, but we have any questions here in the room. You were so thorough, so I wasn't happening. I know. Do we have any online?
Yeah.
Questions?
Yeah.
Oh, yeah.
So, you, green,
Yes,
okay. So that's the syntonic,
element, right?
yes. That's a red,
Which the tonics, we typically start with U epsilon.
Yeah.
And that was our starting place for most of our visual snow patients.
oh, okay.
And really a large percentage are our neurological patients.
Yeah.
So U epsilon.
Okay.
Well,
Because it seems as though it's
they're so
hyped up. Wow.
So you have to stimulate that parasympathetic pathway
Exactly.
and pull them away from sympathetic. So you're gonna go to that green, green and down that blue line spectrum.
Yeah.
I call the right side of the pathway. So that's kind of where you want to go.
Okay. So I wonder if that had something to do with the migraine.
Well, certainly migraine are going to respond more to those. And it may very well have pieces of the puzzle. Because blue is the green tints that we use, or it's a more purified green tint that we use in synthetics. So, and certainly it's a starting point, but we're always kind of moving our way down into that more bluer tints and the purple tints even as we progress through synthetics. So whereas this we're going to keep a constant thing going, constant thing going. So a little variation in it. So in some answers we do both.
Okay.
Yeah, and for the Altius gray green, and for migraine specifically, just keep in mind we're blocking 100% B, we're blocking for 99% blue light. You also have that gray green tint laid on top, the reduction of chromatic aberration and the reduction of visible light transmission to 38%. It's everything is kind of working together. And in regards to the iPRGC cells, their peak sensitivity is right around 480 nanometers. So we're blocking 100% of wavelengths at their peak sensitivity. And what that graph was showing is that a gray sunglasses are blocking 60% of light in that wavelength, and an FO41 is less than 30%. So the fact that we're blocking all of the light at that peak sensitivity, I think that's a major role. And there's a calming effect. So we're doing a study with the University of Alabama in Birmingham that Altius reduces your resting heart rate. So as that tint goes on, you actually feel physical relaxation and a calming effect. And then of course with the amber, I feel like the amber hypes me up. So if I'm feeling stressed, if I'm feeling low, the amber is going to make me feel awake or alert, which for your athletes is great.
And the other piece of the puzzle that kind of where Fred and I were going at it is it makes sense because green stimulates parasympathetic and away from your fight or flight response.
Right.
So it should be positive, right?
Yeah, and it definitely is. I feel like we don't want to wait the second I put it on. Which is BPSS.
Red, it's more sympathetic.
Yeah.
Yeah.
Which as an athlete, you want your heart rate up, you want to be in fight or flight, you want to be alert. So it really just wakes you up and gets you back to my grasp.
But the interesting thing about the amber also, and why FL41 was so successful for a long time, is it does two things actually. You get that stimulation, but it all darkens, but it enhances contrast at the same time.
Yeah.
And that was kind of the magic of FL41. By the way, does everyone know what FL stands for? Fluorescent light. So a lot of people who've had a lot of children having difficulty, and the reason they're having difficulty in school is they see the flicker in the fluorescent light. So it was actually developed to minimize the flicker in the fluorescent lights.
Okay.
So that was the original outset of FL41 right. But the real mechanism is darkening with enhanced contrast and stimulation.
Yeah, well, the nice thing about the amber and the gray green is we can intersect with that 360 degrees inversion, because right now, the light that's shining in my eyes is directly above. So if I had a tinted glass on right now, it really wouldn't be helping because I have light coming from here and above. So especially for patients that just need a little bit more coverage. But I think we have some questions on
Yes. So the first one could be, can you discuss a few aspects of your nutrition protocols for vision snow therapy?
They're asking, if he can discuss some of his, traditional, methods that he uses to reduce.
I'll give you some basics, but I have a nutrition lecture that's about 3 hours long. That really covered the territory. But so for brain, obviously for overall brain health, decreasing inflammation, things like that. Things like magnesium are really good. And there's different forms of magnesium. The glycinate seems to be the best of them. But some people like using the magnesium citrate as a product called Tom. You can get it in most liquor stores, and they have magnesium citrate. A lot of people like those. I like to use turmeric. That's really good to use also. So a mixture of different things like that. The other thing that I actually truly believe in that's to be anti-inflammatory is the CBD. So CBD can be really helpful for some people. You have to pick the right amount. Problem with CBD is they take one of these and they type the dosage, but everyone has different needs because it's affecting that receptor in the brain. Everyone has different elements of that receptor. So some people need a little bit, some people need a lot. So you have to kind of figure out what your proper dosage is for that. That's what they give you as a proper dosage, is not necessarily the proper dosage. But CBD can be very helpful for it. Eating a good diet is also important. Minimizing carbohydrates, healthy fats, getting away from the American diet, basically. It can be really important. Eating a proper amount of protein is also very important. There's also anti-inflammatory diet. Look at certain foods you eat, certain foods you should avoid. Sometimes the foods you avoid are the foods that we all love. But certainly, if you have proclivity toward inflammation, limiting and doing the right thing. The other big nutritional supplement that is huge, omegas, omega-3s, huge. We use them on virtually all of our patients. So I'm thinking a good quality omega is important also because they come in two formats. You have your omegas that are what they call ethyl ester format, which they come in the big bottles at Costco, and you take them and you burn fish. That's that format. But what the other format, there's different brands you can take. They're called a triglyceride format, and they go through a process that they call de-esterification. They pull out all the alcohol for purification, and it takes away that fish taste, but it also is much more potent and much more positive effect on the brain. So and much more absorbable too, yes. So certainly omegas are a huge element of our arsenal. There's also things called SPMs, and something mediators, exactly what they are. But for more acute inflammation, the SPMs work actually really well. They're oil-based also, and so in certain cases, I'll use SPMs first, and then I'll switch them to omegas later. So lots of different things you can look at as far as nutrition goes, but the real key with nutrition is, and then also being a very good, multivitamin to make sure that people are not eating right, they're not getting the right nutrition. Going outside, I talk about that too. Vitamin D, okay? The only way to get vitamin D outside of a supplement is to be outdoors, okay? We know that from myopia. Even in myopia, treating myopia or slowing down progression of myopia, tell a child to go outdoors 2 hours a day, it's going to increase the rate of myopia. But it has a lot of other effects, especially with inflammation. So vitamin D is really important. So getting people to go outdoors. And the last thing that I talk to people about, and there was a nutrition question, but I'll go back to it again, is sleep, getting good sleep. So hopefully that answers your question.
What's the standard protocol to get Altius?
Standard protocol to get Altius is what the question is. Step one, open an account with ABB. So they are our exclusive distributor. We are not available for anyone else. So if you have an existing ABB account, you can go online and order right away. Performance Nutrition Technologies is the company and Altius is the product. And it is on their website. You can email, call, and then you can also contact someone on the Altius team as well. I do have a 40-minute presentation about the Altius Advantage, just going really deep into the science of the product, the different tints, different applications. which sports to wear, which lens, all of that stuff. So please reach out, and either myself or my associate Josh will meet with you virtually and answer any questions.